objectively or subjectively, it's up to you, would you say that foot and ankle orthopedics is the hardest of the orthopedics? So I've heard hands pretty hard, but being a podiatrist, the foot and ankle just seems, probably the foot it just seems super complex with all the joints in there.
I mean, look, it's hard, right? You got to realize there's not many of us, right? If you actually look and try and find foot and ankle orthopedic surgeons, there's not that many. And that's not because there's not much work. There's heaps of work, right? It is, well, look, it's harder, I reckon it's harder than, say, hip and knee surgery, right? The hip and knee surgeons have got these operations that work really well. They've got a like 90-95% success rate. They can do it over and over and over, same operation over and over again, like a knee replacement. Most part, you do the same steps over and over. So you get really, really good at it really fast. Foot and ankle, the foot's got, 28 bones in it, right? You do something in one thing, it often sets off a problem in another area. And the surgeries are all very different. No foot's, I mean, you would see this plate, right? No foot's the same. A flat foot's never the same. A high arch foot's never the same. Even Achilles is never the same. So I think it's much more challenging, say, than a hip and knee surgery. I didn't particularly enjoy upper limb surgery as an orthopedic surgeon. I still do fractures. I think those surgeries, shoulder surgery and hand surgery is difficult in its own right. So I can't say necessarily it's harder than those. And spine surgery as well, you're dealing with this big spinal cord, which is, you injure it, it's big complications. So look, I reckon it's up there. Whether it's the hardest, I don't know, but it's definitely difficult. And the thing is the operations we've got, the success rate is never up at the 90-95% success rate as compared to a hip and knee surgery. Like ACLs, total knees, total hips, like total knees and total hips are probably the most successful operations ever invented to date, right? So in regards to those surgeries, no, it's got to be harder than that. Well, I know it's harder than that. Yeah.
I'm putting you on the spot a little bit here, but tell us your ideal patient. So the ideal injury walking through your door, what would that be?
I really like sports injuries, right? That's my thing. Like when I was in Brisbane, the guys I work with, they deal with a lot of sports injuries. That's the stuff I like seeing, and particularly my area of interest, syndesmosis injuries, right? I reckon it's funnily enough, like as an orthopedic registrar in my training, I didn't see one that wasn't associated with a fracture. I was never looking for it, right? We actually you don't get any training on that. Funnily enough, all the orthopedic surgeons that are coming through in Australia, they don't get any training specifically on a soft tissue syndesmosis injury. So my ideal patient is actually like a 24-year-old, let's say Newcastle Knights player that's injured his syndesmosis on the weekend, been picked out by the NRL physios, his mechanism of injury on a video, so I can easily see it, and take him for a scope and stabilize his syndesmosis, and they do really well. And that's my sort of thing that I really enjoy seeing, I guess. It's not super hard surgery, but it's the interesting patients they rehab well.
Oh, yeah, I was reading, and on your bio on your website, which is hunterfootandankle.com.au, your training, your background, like you've worked obviously over in Canada, but up in Queensland with a lot of, I'm assuming, foot and ankle orthopedic surgeons that have a huge sporting background. So you've obviously trained with them and that kind of thing.
Yeah. I mean, I can't sit here and say, look, I directly treated a North Queensland Cowboy or something, but I work with the guys that treated them, and as a result, I learned how they do things with those players, and I've been able to extrapolate them to professional athletes here in Newcastle, which is great. And then, look, I just enjoy seeing those type of patients. To be honest, that's not to say I don't enjoy the rest of foot and ankle surgery, but they're the things that I really like, and I think it's like syndesmosis injury is an underestimated injury and very difficult to pick up, and there's heaps of research probably still to come on treating those injuries.
When I was writing these questions out to you, I had a bunch on syndesmosis, and I was like, oh no, we'll save that one for another time. So, so we'll keep that in mind, and we'll come back to all the syndesmosis stuff.
Yeah, so we'll start off what I think quite easy for you. We had a question come in asking about an accessory navicular bone. So it's been removed, the likelihood of it growing back, because this person's feeling like they're starting to get a little bit of extra, or starting to get a little bit pain, or starting to get pain back in that area, which is on the inside of the foot, top of the arch.
Yeah, look, I, to be honest, I've not seen any that actually come back, but I've definitely seen patients that have I've seen a few netballers, for instance, that have had an accessory navicular removed when they were a teenager, and then sort of present in their sort of mid-20s, early 30s, with pain over the medial side of their foot. Now, the accessory navicular comes in all different types, right? You can have a very small one, or you can have a really big overgrowth. And as a surgeon, it's actually a little bit challenging as to how to remove, whether it's like how much to remove in some cases. So if you've got like a little piece, that's pretty simple. But if you've got a big overgrowth, you feel like you're taking an awful lot of the navicular out when you're doing the surgery. if the patient's got some repeat pain, I suspect either there's still some left, or they might have something to go with the accessory navicular. So some patients will have a flat foot or they'll have some tibialis posterior symptoms with the accessory navicular. And so that's what I would actually be looking at probably more closely. I doubt it's actually come back, right? Yeah. So most accessory bones you take out in the body, they're not going to reform. So I suspect, so the operation usually involves you take it out, you grab the tibialis posterior tendon and you basically put something called a suture anchor in, which is almost like a screw. Yeah. And out of that screw type thing is some stitches and that reattaches in the navicular. So some patients, like the ones that I've seen that have come back with pain and they are challenging, it's usually something either to do with the tib post tendon or the fact that there's still a fair bit of overhang of the accessory navicular, which means you've got to be more aggressive in taking it out. In saying that, when I started my practice, I was very aggressive about taking them out. And over time, I've become less confident in that operation. And so I actually work quite hard in trying to treat them non-operative, but much more aggressively trying to get them sorted with a non-operative approach. Obviously, surgery is always there, right? But these people have been born with this. You'll find, you'll see lots of x-rays in patients for other reasons that have an accessory navicular and no pain, right? And that's the mystery of foot and ankle surgery. You can have an osteochondral lesion of the talus and have zero pain, right? But then you've got these other patients that have horrible pain. So, look, I would heavily go on, even in this patient, if they've got what we think a regrowth, they probably need an X-ray and they probably need an MRI to look at the tibialis posterior tendon to begin with. And then whoever's treating them else has to look at overall how their foot is, right? If they've got a flat foot, there might be another reason for their pain.
I guess if you're removing a bone, then it has potential to kind of change or alter their biomechanics. So then you would be loading tissues differently and things can pop up.
Yeah, the tib post tendon is very sensitive to any change in its length. Right, so you only need a couple of millimeters and change the length of the tib post tendon for the mechanics of that tendon to be greatly affected as well, right? And so that also worries me as a surgeon, taking this piece out and then reattaching it, right? Your tendency is to over tighten it because you don't want to put it loose because you think that's going to cause much more of a problem. But you still always worry about when you're reattaching a tendon, knowing how much tension exactly you need to put it in, right? There's that's an experience thing. There's not a magic way of doing it. We don't have
Do you
that
mean
yet,
like
anyway.
Tendinopathy? Is that what you're sort of implying? Or what
So,
happens?
The tendon can either be inflamed or it can have a long degenerative process potentially. So I say, look, to be honest, if you had that operation initially, I'd say to most people it might be 12 months before you get a complete cessation of pain, right? Because you're taking out the piece of bone and that's causing inflammation in the surgery itself. You're reattaching the tendon. It takes a while for that tendon to bed back in. And you're also sticking some sutures in the tendon, which promotes a response as well.
Yeah, that's crazy. I mean, we talk about, like with patients, giving them a new exercise, there's some risks associated with that. And then for you, it's talking about, a tendon transfer risk. It's funny the perspective you get between each profession. But that's, I did want to ask, and it's probably the theme with all these questions, and it's a common thing that we get asked all the time, and probably lucky where we work. For other people that probably don't have access to talk with someone like yourself or sports doctors or doctors and things like that, when do you think a referral is warranted, or more so an opinion is warranted? And using this case as an example, if someone comes back in the clinic and you've tried that non-operatively, is it a time thing, or if it's, if you only get it to a 2 out of 3 and they're like, it's worth an opinion, what would you recommend for someone?
You're talking about this particular case or just in general?
Yeah, it probably in general, I would think.
In general? Yeah, I think it's a tricky one because it depends. It's going to depend a little bit. So, for instance, you and Kelly, reasonably experienced clinicians now, right? You've been doing this for a while. So, I imagine if you've got a case, if you're pretty confident in the diagnosis, then for you guys, for instance, like I would be, extending your non-operative treatment as far as you think you can get. That might be, say, for instance, most things that'll be 2 to 3 months, right? Most things are going to show and you want to see some improvement in that time. And if you're not getting there, then you've got to think, well, okay, do I have my diagnosis right? Or is this patient just not getting better purely because non-operative treatment's not, not working? And I would say, if you're a starting clinician, then you've got to be a bit more careful. Or if you feel like you don't have a lot of knowledge on a topic, then you've got to be a little bit more careful. I mean, surgeons in general, we shouldn't be turning down referrals because we think it's beneath us, or, you know, we're lucky that we've got the knowledge we've got. And some, like a lot of my practice, it's interesting. Your speaker from London was saying his conversion rate's like 5 to 10% to an operation.
Good.
Mine's exactly the same.
Yeah.
I see so many patients, and I go for sometimes 1 or 2 weeks without booking an operation.
Yeah.
Right.
Yeah.
And I consult him like 2 or 3 days a week minimum. And so a lot of those patients just want one single opinion. They've been referred by a physio, podiatrist, GP, and you just say, yep, what they're doing is fine. Right. I agree. Don't need an operation. This is the diagnosis. So, but I guess if you're an inexperienced clinician, if you're not sure, you either ask one of your experienced colleagues, right? Or if you really feel like you're out of your depth, then, you know, like if your surgeon's approachable, you just give them a call, you send them a text, right? Not everyone's like that, obviously, right?
Yeah.
But an early referral in those cases is absolutely fine, just to check, you know, what you're doing. It inspires confidence in the patient as well, right? If you've got the clinicians all saying the same thing, then that certainly helps. I think for experienced clinicians, GPs, physios, podiatrists that are confident in their diagnosis and confident in their non-operative management, then a 2 or 3 month period would probably be appropriate. That's, you know, it's a difficult question to answer because there's things that are going to be appropriate. Not, for instance, an Achilles tendon rupture. If that's going bad within the first couple of weeks,
you're not waiting 6 months for that one.
You hold on for 2 or 3 months. That makes my surgery much harder, right?
Yeah.
So it's, you know, it's a bit injury dependent as well.
Yeah, good answer.
Yeah, good. I'm going to clip that because we always talk about that, like either, you know, the diagnosis may be wrong or there's just a treatment or something that you can't offer. And there's no harm in getting an opinion. And I think I'm glad you mentioned the conversion rate, because the people that we've talked to, they were under the impression, you know, that everyone that sees an orthopedic surgeon, they're just going to get surgery or an ankle fusion or like a triple arthrodesis. And it's like, it's likely just to be an opinion and then go, yep, everything you're doing is fine. You don't need to see me again.
Where do you think that sort of misconception comes from, Steve?
I also wonder whether, I mean, that's for an ankle surgery, right? So like I said to you guys about the success rate of the operations, they're not bad, but they're not as good as hip and knee replacements, right? So my colleague, I work with 2 hip and knee surgeons. Their conversion rate would be quadruple mine, possibly even 40, 50%, right? And that's because knee arthritis, hip arthritis, hopefully out there, the non-operative treatment is reasonably well known, right? And so when they're getting the patient, they're ready for surgery, right? I do think also because we weren't probably as good at non-operative treatment maybe 20 years ago. I might be completely wrong. You guys might kiss me emails.
No, you're right. You're right. We're giving out stretches and things.
Yeah, but I think we've sort of learned over, like, I guess people used to see surgeons and we like some of these operations, like people were getting triple arthrodesis for all sorts of things, right? And they're getting done differently to what they are now as well, right? People used to get, well, I wouldn't say everybody, but some patients were just getting fused in the position that their foot was in. So there's horrible flat foot, and they were just fused in that position, and they end up hating that operation. So these operations get these horrible names attached to them, right? That they shouldn't be done. It's hard for me to put a finger on. Definitely, I know from the colleagues I work with that you will stop getting referrals if you are that gung-ho when you're operating on everybody. Right. And the other thing is your complication rate will go up through the roof because if you're operating on patients that don't need it, you are ultimately going to be asking for trouble. Right. Yeah. So, and the hardest part of surgery, funnily enough, is not actually the surgery itself. It's the decision making, right? Particularly in foot and ankle surgery. But the things that keep me up at night is not whether I can do the surgery or not. It's whether these sort of steps that I'm going to do in the operation are the right things for this patient, because I don't have a patient that's awake and walking when I'm doing the surgery, right? So I guess that doesn't really answer your question. I can't put a finger on it, but definitely the good surgeons I know don't do that. And I wouldn't say there's many surgeons out there that would be just operating on everybody. Whether that's a market pressure thing in some places, you have a saturation of surgeons in certain areas of Australia. Sydney would be one, right? Where surgeons, like everyone else, have to make money, to live. Now, if you have a lot of surgeons in a small area, now I'm not saying this is for ankle surgery, this is just surgeons in general. There's actually been studies that show that the operation rate goes up.
Wow.
Right. So I think, so I can't remember if it was in Adelaide or about 10, 15 years ago, the Australian Orthopaedic Association looked at some numbers, and I think it was in Adelaide, because I think Adelaide had a high concentration of orthopedic surgeons. The knee arthroscopy rate was much higher in that city than elsewhere, right? So, but with it, I mean, there's a whole lot of confounding factors to that, but that may be where some of that's come from. But I don't know, that's a tricky one to answer. But definitely, like a good surgeon, unfortunately, like we love operating rather than, I've got to say I like operating the most out of my job. It's the most fun part. But I hate complications and I hate things going wrong for the patient. And so that's why the conversion rate is so low, because you're really trying to pick the right patient in surgery. Right.
I wonder if we had like a big group of podiatrists, there'd be heaps of custom orthotics getting given out, similar things, and study on that.
Maybe, maybe.
Wouldn't surprise me.
Yeah, like I guess, and that's the other thing you see, allied health and surgeons, everyone's trying to sort of skill up or add extra skills to their bow as well, because it's a market. Unfortunately, health is a business.
It is a business. All right, Kelly, you want to ask this question? I'm keen for this one. It'll be interesting.
This is another listener question that we had sent through, yeah?
Yeah.
So we have an elite snowboarder who has congenital vertical talus and has been told is required to have a triple ankle fusion and Achilles lengthening. He wants to know what he should do to make sure he's right pre-surgery and what other advice you would give.
Which we know is hard because you don't have the context and it's a couple of lines and surgery is very complex. But I mean, general advice.
Yeah, right. So that's like a real left field one, right? Like that's like congenital vertical talus is like rare, like really rare. So like that'd be picked up when you're born, essentially. That's like congenital. So patient have a rock and bottom foot. So they have a very, very flat foot, but their heel's actually in the equinus. It's actually sitting up. So all these patients, their heel actually won't touch the ground. And often the talar head's actually sticking out on the bottom of the foot. So the question for this, like, the fact that this patient's actually got to be an elite snowboarder, is amazing, actually, right? So, like, the fact that they're just at that level is incredible. But it's a tricky one because the pathology is tricky, the pathology is rare, and the surgery's big, right? So, triple fusion means you're fusing the three main joints of the hind foot of the foot, which are responsible for almost all the movement of the foot, right? So, this patient, if he's got a congenital vertical talus, he might have had surgery when he was a kid, depending on where he is. Like most patients would have surgery when they're a baby. They might have some plastering initially, and then surgery to correct the position of the talus. Or they used to actually release a whole lot of ligaments around the foot to actually reposition the talus. So we've gotten better at that. That would be done in a specialist pediatric orthopedic centre, at least in Australia, right? So it's not definitely I wouldn't be operating on kids. With that problem. But we do, I've maybe only seen 2 as adults ever, right? And I probably haven't seen any in the last 2 years. So they're not commonly out there. As for the patient, what he can do to help him with surgery, I mean, what you guys have talked about previously in other podcasts, anyone leading up to surgery, the more strength they can get, the more tissue capacity they can get, the better their outcome is going to be post-surgery, right? The more, because surgery is going to result in you having muscle wasting, you're going to lose some proprioception. Recovery for this surgery is going to be 12 months minimum, right? He's going to be possibly 6 to 8 weeks or more before he's walking on the foot. But I always said my advice to this patient would be actually really nailing down from the surgeon what they think is going to happen after the surgery, right? So, I said I really like operating on athletes. They're really tricky when it comes to pathology like this, right? Because a triple arthrodesis, a triple fusion, if the surgeon's doing it properly, they're going to alter the mechanics of his foot significantly, like alter the shape of his foot significantly, right? If he's an elite snowboarder, he's been getting away with this type of foot for a long period of time. All of a sudden, his foot's going to feel different in the boot. It's going to look different in the boot. And I would be saying to this patient, look, I don't know if you're going to get back to snowboarding, if I'm being honest, right? The main reason for this operation is actually to relieve pain. That's its job, right? Everything else on top of that is a bit of a bonus. So that's for him or her, whoever's asking this question, is really nailing down what the expectations are post-operatively, more so even than doing any pre-operative rehab, anything like that, because things like range of motion and things are not going to preoperatively are not going to make a difference because he's going to have quite a stiff foot anyway. But the more strength he has in the calf, lower limb, that's going to be helpful. But he really needs to be sure the patient's got to really be sure what they're getting themselves into. I would say probably the surgery is going to be appropriate because they wouldn't really be this, like most patients in their 20s, if they've had this problem, they're probably going to have pain, possible callosities, difficult to function, but they're obviously functioning pretty well if they're elite snowboarders. So they just got to weigh that up. How bad are their symptoms now? Because I would say there's a possibility that they may not get back to doing what they like doing, or even at the same level. And that's just got to be an honest conversation. So the patient's just got to be aware of that. That'd be the single biggest thing.
Yeah.
And if they were seeing me, I'd have 2 or 3 visits with them to revisit it, because there should be lots of questions, right?
Yeah.
Something I was having a chat to someone a week ago or so about in knees and knee replacements, about mechanical alignment versus kinetic alignment. Is that something that you talk about or think about with something like a fusion as well, or an ankle fusion, or not so much?
Not so ankle fusion is actually a tricky operation. So because your principle of an ankle fusion is your patient basically needs to be able to get the foot to the floor. So you don't want to put them in any plantar flexion or they'll start walking on their forefoot, and then they'll get lots of pain in the forefoot and they'll hate it, right? So purely, so when we talk about knees has become a fad to do kinematic alignment, which is essentially trying to say they're trying to put the patient back to where their normal anatomy is my understanding. Whereas typically with knee replacements, they were trying to restore mechanical alignment, which is, I mean, that's a whole other topic to talk about, but it's, so, and there's pros and cons to that. And anyway, no, I guess an ankle fusion is different in that, and purely we purely want to put it in a functional position for how the patient is at that point in time when we're doing the surgery. That actually becomes a problem though if someone does a knee replacement above it, right? Because if someone does a knee replacement above it, it changes the mechanics down the foot, right? And then the patient all of a sudden might be walking more on the lateral border of their foot or medial border of their foot, and all of a sudden an ankle fusion starts to hurt. So purely though with an ankle fusion, we're really just trying to get heel to the ground, and we want the patient not in too much valgus or too much varus. We want them close to neutral or a little bit of valgus, basically. And that's typically what we're always aiming for, because they basically just need to be able to walk without pain.
Yeah,
great. God, they're going to appreciate that. I bet they didn't thought when they sent the question through, because they sent it through just for the timing.
They probably weren't expecting that answer either, I would say.
But I think it's good. But
it's good, I think that's what they probably need to hear. It's probably what they're not thinking about, I'd say.
Yeah, it's good. So talking about our next topic of talar dome lesions, and I want to get your opinion. Like, do you think these are common in clinical practice? Because I know even when I was a new graduate, like in my first 6 months, I didn't really see them at all. And I think that I actually did see them, but I just didn't diagnose them, and they probably were mismanaged and went somewhere else and did get diagnosed. Do you think they're more common than what people think?
Oh, absolutely. So there's studies they've done where they've just MRI'd ankle sprains over and over for like 200 patients. And funnily enough, there's probably I think the paper somewhere between 50 and 70% of ankle sprains have some level of OCD. Now, that doesn't mean they're bad. Like that might just mean they've simply got some bone bruising or something like that. But they're much more prevalent than we probably give it credit for. Right. But in saying that, they're a tricky one because, like I said before, some of them are symptomatic and some aren't. Right. And so if you talk about things like X-rays are only going to pick them up maybe 30 to 50% of the time. That's what the literature would say. So an X-ray is going to miss a lot, basically, right? Then the question becomes, well, we can't MRI everybody. We can't CT everybody. Like ankle sprain is the most common injury in the world, right? So you've probably seen, I've probably seen heaps, Blake, and you've probably seen heaps. The same with you, Kelly. And we've missed it, but it has never caused the patient a problem, right? I think the important thing is to think, well, patient's not getting better from an ankle sprain after a few weeks, like 5-6 weeks. There's something else going on. That's the key to sort of think of, right? Is you can't just ignore the patient and say, it's just a sprain. It's going to get better, right? We just got to have it that, okay, it's obviously a safety net. The patient's not getting better. We're going to go looking for stuff.
How would you explain? I probably should have started with that first. How would you explain a talar dome lesion or an OCD lesion to someone younger, or even to a patient, I guess?
Yeah. So the typical medical name for it is an osteochondral defect, which osteo means bone and chondral means cartilage, right? So it's a cartilage and usually a cartilage and bone defect. So what that means is that I basically mean it's almost like a piece of paint coming off the wall. basically, right? So usually I say to the patient, oh, look, your joints are covered in cartilage. It's like nice, it's nice, smooth stuff. It's got low friction. It's really important for the joint to move easily, but it's a little bit like porcelain. It's pretty brittle, and it can chip off if you have a bad injury, right? And underneath that is bone, and bone is fantastic structurally, like it's really strong, but it's a little bit like sandpaper in its consistency. So we don't want to expose the bone. But unfortunately, when you have a lesion like this, it's basically like the little chip of the porcelain's coming off. And underneath is the sandpaper bone. And if you then got sandpaper exposed, it can rub more porcelain off from somewhere else in the joint, right? Now, unfortunately, fortunately, I guess, is that they all come in all different shapes and sizes. So what I mean by that is that some patients just have some bruising of the bone underneath the cartilage. Some patients have chipped the cartilage, but it's not actually moved off or fallen off, and it's still held on a little bit, so it's not going to come off. Other patients have a big piece of bone attached to the cartilage and it's floating in their ankle and needs to be reattached. So it will depend a little bit. Usually I've got the image there and I can point out here it is, and then I say, well, look, this one in yours is okay. It's sitting where it's supposed to. It's got a little bit of bone attached to it. If we stay off for 6 weeks sort of thing, I'm pretty sure it hopefully will heal kind of thing. But they come in all different, like there's a wide range of how it presents, unfortunately. And the other thing is there's a lot of operations for it.
Yeah, our next question was the management.
The general rule in orthopedics is the more operations you have for something, the less likely those operations are to work, right? So if you've got a lot of treatments, something like look at forefoot surgery, right? There's like thousands of treatments, which usually means that the ones you've got don't work that well, right? So treatment's a little bit dependent on the lesion, I guess, right? So if I've got someone that's had a really bad injury and I can actually see on the X-ray they've got an osteochondral defect and it's come off, and I actually see a big piece floating in the joints. If the piece has got a fair bit of bone attached to it, that's a good thing, because I can actually put it back to where it needs to be with surgery and hold it there with something. I can't actually put cartilage back on, right? So if cartilage is attached to bone, I can get bone to heal, and by way of that happening, the cartilage will stay where it needs to. But if it comes off with a small piece of bone that I can't, or just cartilage itself that's floating in the joints, I can't put that thing back on. I've actually got to take the cartilage out because it's just going to get stuck somewhere in the joint, right? If I've got a bit that's chipped off and the bone is exposed, typically what we do is do something called a microfracture. So what that means is we look inside the joint with a camera and an arthroscopy, and we actually drill some little poke some little holes in the bone that's exposed. Yeah. And the idea is to provoke a healing response from the bone so the body forms basically something called fibrocartilage. And that's probably effective around about 70% of the time.
Yeah.
It's dependent on the chronicity of the lesion and the size of it and those sorts of things. And that's probably the most commonly performed operation for an osteochondral defect of the talus. And then you'll find that there's still some patients that aren't better, right? Or they have a bigger lesion. Some surgeons in that case would actually take some cartilage from the knee. They take some cartilage and bone from the knee. It's called an Oates procedure. And they'll then go and reinsert that into the talus, right? Okay. And that's probably a similar success rate to the other modalities. And then in the States, in America, they actually take what we call allografts. They take talus out of a dead person and pop it in. Wow. I'm less familiar. Like, I know that procedure works. I'm less familiar with the success rate of it. And I haven't typically seen it in Australia.
Yeah.
There are other therapies where there's pharmaceutical companies that have developed injectables where they basically claim that fibrocartilage will form over the top. The debate's probably out on that at the moment, and whether they're actually successful. Most of the studies on that have been commissioned by the companies themselves.
Yeah.
And we just recently, I think, lost the Medicare rebate for that in Australia, which usually suggests that they don't think there's enough information that it actually works. So, I mean, that might improve over time. But it's tricky. They're tricky. I'll be honest, they're tricky lesions.
Are they only? Sorry.
Right, no, go on.
Are they only getting picked up on X-ray if the bone's coming with the porcelain?
I think more often than not, yes.
Yeah.
You won't pick up a cartilage lesion unless there's a obvious like a really big defect.
And do they use like cortisone or things like that in any injectables in the minor ones? Do they?
Yeah, look, we do. Like, so, and then you're really after a symptomatic benefit with that. True. So, I mean, typically, that's the other thing which I probably didn't talk about is that a lot of the time I'll be trying to get patients off these lesions for a period of like 6 weeks, right? To see if we can get some level of healing or just dampen down the inflammation, stop the shearing effect from weight bearing. And then we're talking about where patients don't say I have a big piece that I can reattach, essentially, right? And then you might do a steroid injection with the idea that you're just trying to calm down the symptoms. Or sometimes I'm using an injection to work out that that's the actual pain generating area of the ankle, right? They might have other pathology. And in which case I'll say to the patient, look, to be honest, the steroids, like a flip of the coin, whether it's going to work.
Yeah.
But the local anesthetic's useful because we're going to inject around this lesion here under an ultrasound so we know where it is. And if you get a lot of relief in those first 2 or 3 hours after the injection from the local anesthetic, that tells me, hey, that's definitely the pain generating site, never going to deal with it, right? But so yeah, I think that's I should have brought that up earlier, Blake. Yeah, that's probably that's a reasonable way to go about it. Things like anti-inflammatories, staying off the foot, and then steroid injection if you're not getting anywhere are definitely three. Like, sort of, they're probably the three most common ways of managing it initially. And then if you're not getting anywhere, then you can proceed over those surgical options.
With especially with a sporting person where, time getting back to play or activity or training is pretty important for clinicians that are concerned of maybe an OCD, it's probably better off, because I know some clinicians that'll send for an x-ray, wait for that to come back. And then if they don't find anything, they'll try a little bit of time again, and then they'll send off to you guys or to the GP to see you. Do you think it's better to send off, again, if you haven't got that initial improvement, better to send to you probably initially because you'll be able to get the correct imaging and then just manage it quicker? Because I know x-ray is probably not going to be worthwhile in this.
I guess that ultimately comes down to like how does the management change if it's there versus not, right?
True. I mean, I still go back to that one before, right? If you guys expect, I mean, most of these injuries are going to present very much like an ankle sprain, right? Yeah. I think it is still reason. I mean, and when you see an ankle sprain, some of them are really, really painful to begin with, really swollen. Others of them are very minor, and the OCD can occur in either of them, right?
Yeah.
I still think you treat an ankle sprain as you would normally, and then if you're getting to that provided your experience of managing ankle sprains, right?
Yeah.
You get to that 5 or 6 week mark, you're like, well, there's something not right? This patient's not improving. There's this one spot where they're really sore always. There's some other reason for it. And I would say that's the time to refer. I mean, I'd love to see them all at 1 or 2 weeks, but that's not like, I'd be seeing heaps. It's not realistic. Like I said, the ankle sprain, what is it? Like, I think ankle sprains make up like 7 to 10% of emergency presentations in the US, right? Wow. Like, it's not like it's the most common injury in the world, right? I think it's interesting that there's some guys called Aspetar, which is a sports medicine group in Dubai, which they like to class themselves as the leading people in sports medicine, but they've done quite a bit of research into ankle sprains. And they're saying, look, we really shouldn't be calling it a sprain. Like they said, well, if you had a patient with a knee injury rock up to emergency, the terminology used would be like, well, they had they had this injury, this is the mechanism. We felt a pop, they're a bit lax on anterior jaw. It's probably an ACL, right? Or an MCL injury, right? They don't usually say you've got a knee sprain, right? The same stuff, the same should be applied to an ankle sprain, right? Like 40% of ankle sprains are still painful down the track. So it's funnily enough, there's been studies that show even with an inversion injury and an ankle sprain, where same thing, where they MRI'd everybody consecutively, 20% of them were found to have a syndesmotic injury as well, right? Which makes absolutely no sense, right? You're an inversion injury, completely opposite mechanism of a syndesmosis injury. So I guess the thought's got to be, okay, yes, most of them get better, but they're not benign injuries, right? So you just can't just say it's an ankle sprain, it'll get better, don't worry. You got to watch it 5-6 weeks, do your proper rehab, and if they're not getting better, okay, either I get some more imaging and probably more than an x-ray at that point, but an x-rays definitely should be done. Like it's a good first baseline. Like x-ray is underestimated, right? There would be nobody that gets referred to me, even for what we think is mostly soft tissue, that doesn't get an x-ray. I'm not saying every ankle sprain should be x-ray, because that'd be also crazy, right? But if you've got a patient that's 5 or 6 weeks down the line, that's not getting better, an x-ray first. If that's normal, you've probably got to be thinking of some high level imaging, that's probably an MRI. But that's a bit dependent on what the presentation is.
Yeah, I like that. I like imaging. You don't really like it that much, hey?
I often X-ray ankle sprains.
Ankle, yeah.
I'm just thinking of a patient that I have at the moment who's probably almost 4 weeks down the track after an ankle sprain, and it's just a really nasty one. We've had her in a boot for the last 4 weeks, and every time we try and take her out of the boot, it's still just super painful. And so I'm suspicious of a talar dome lesion or an OCD. That's all quite helpful for my thinking as well. Everything that you've said with her.
Yeah, I mean, it looks tricky, right? So you almost just like could have a peroneal tendon injury or something like that too, right? Like or a deltoid injury, you know?
Yeah, a deltoid. So it's the medial part is super painful for this person that I'm thinking of. And that's something that I was going to ask you about, because it often is involved, and I can just never quite get my head around why or how.
Yep, don't worry, I can't either, right?
So the deltoid ligament in ankle sprains, it just doesn't make sense to me.
Would it just be like a compressive?
Why is it stretched then?
Would it be something compressive?
Well, it's interesting, right? Like, so I agree. I can't get my head around it very easily either, right? So, but what I do know is that from those MRI studies that if you have a low ankle sprain, so an inversion injury, almost up to 50% of the MRIs will show some level of a deltoid injury, right? So it's not uncommon. It's really common. If you go watch a video of a cadaver that's brought into inversion, you actually see that it looks like what the talus does is it sort of shifts laterally a little bit first, and then it internally rotates and inverts, right? So you can sort of see how those anterior fibers of the deltoid get injured, right? But for the more severe injuries, I struggle myself to work out how that happens. I definitely see lots of it, right? But that goes by the same token. There's quite a few lectures now that have been saying, well, we don't understand low ankle sprains as much as we thought. Like, for instance, the syndesmosis injuries that you find on an MRI after patients that almost clearly had an inversion injury, that makes no sense, right? So there's something, I suspect that often because the mechanism is more complex than we think, right? So some patients are just going to fall straight into inversion, right? But I suspect in some cases there's more than that, or it's more severe than we think, right? But I definitely see it. And so, but the mechanism is interesting, right? Like, so I've tried to look into this quite a lot. There's not a heap of information for people talking about the mechanism and how the deltoid is injured. You guys might get a whole lot of emails from someone who's got a paper that knows it, or a surgeon that's like, well, this guy's talking garbage. It's clearly this, right? But I have attempted to research it, and I haven't found great explanations on it. So, but it's definitely out there. And then deltoid injuries themselves are there's a lot of debate as to how to manage them, right? So that's like a very tricky topic. Each surgeon will tell you something different. The literature is not clear, basically, on deltoid injuries.
On that topic of like the research and the literature not being clear, and I've tried over the years, and one of our topics we're going to talk about, like plantar fascia tear management. There's a lot of people that have a great understanding or say they have a good understanding, but when we look at the research over the other side, that there's just not much there really, like,
particularly
at all.
For partial tears. We had a patient earlier on this year who we found to have a partial plantar fascia tear, and Blake and I were both trying to research about it, and we're like, there's nothing.
There's nothing. No, there's not much there at all. All I can say is that from a surgeon's perspective, right? If you've got, I mean, I tend to think it's got to be related to plantar fasciitis, right? Although some patients don't have those symptoms beforehand. But surgery for plantar fasciitis, not that I'm saying that's a good idea, is to release part of the plantar fascia, just like a tear would be.
Which
right?
is it hard? Do you mean release?
Release,
yeah.
So it's, we get a knife and we take off.
I just want to add one thing quickly, because I know we talk about a lot and we always talk about this. But anyone listening to this that talks about releasing muscles with soft tissue work, this is actually releasing a muscle. You're not releasing it when you're massaging. I just want to say that quickly.
No, definitely not. It's actually quite hard to release with a scalpel, right? So
so your thumbs probably aren't cutting it.
Thumb's just not going to do it. Good, even if your nails are pretty sharp.
You're not getting there.
No. So, no, there's not much out there. Look, that is one, maybe I'm sticking my head in the sand, but that is one injury that doesn't, as a surgeon, doesn't worry me very much. Like I can't say I've ever had to repair it. And it doesn't, to me, make a lot of sense to repair it.
Are you talking about a complete tear or a partial tear?
Either.
All right. Okay, right? Cool.
Like I said, with implantar fasciitis, we release it as a treatment option. Anyway, it's not the world's most successful treatment option, right? But that's how we do that surgery. And so, I mean, the worry that we have with that is whether that causes a flat foot or something like that.
Issues.
But your chance of actually repairing that thing well surgically is not great. It's like, it is tough tissue when you release it, but then to go to repair it, you're not going to get a great hold. And I don't think you'll see a difference in the patient's symptoms. What I can say is the majority of patients, I don't know if this is your experience, but the majority of patients will recover.
Yeah, they'll be fine.
3 to 6 month period, right? With most often no repercussions. It's painful at the time, but they will do very well with a period of offloading and then rehabilitation.
Yeah, we even just like a simple, cheap, orthotic, and sometimes you use a carbon plate, plenty of taping, some compression socks, a stiff rocker bottom shoe.
High-dose cuddling.
Yeah, just cuddling as much as you can. Obviously doing it only as much as you need to, but generally it is painful, but it gets better. Would those fibers, would they reattach and be scar tissue? What happens?
They're most likely just going to scar up. Realistically, they may not. I doubt they'll reattach.
Yeah, because I know patients ask that. They'll be like, and I always say it probably doesn't matter what the outcome is, because as long as we rehab you back there, but it'll just scar, you would say?
That's right. Yeah. It'll just scar. It'll just scar.
What about if it was quite a young person and it was a traumatic sporting injury with a complete tear and they wanted to be a 100-meter sprinter or something like that? Would that change your management at all, or still not really?
No, probably not. Okay. I guess I think about long and hard if they continue to have pain, but I doubt long term it would affect their sprinting. I'm not saying that the plantar fascia is a minor player. It's a reasonable player in terms of supporting your arch, but it's not the only player. Yeah. Right. So I mean, I'm just speaking from personal experience. This is not literature, but and it's more often than not these things are happening in active people. They're not often happening in sedentary people.
Yeah, I was going to say I've only seen it in active people.
Yeah, and they recover very, very well. It's just purely that they don't. You just got to make sure they don't have pain. I just think your surgical repair, like the other thing is where you would make a cut for a surgical repair is a terrible place to put an incision for a runner, basically, right? So, I mean, I'm not saying I'd never do it. I haven't had to do it, but that would my reasoning would be if they've got ongoing pain that's impairing their function. And I'd probably get 2 or 3 opinions from other surgeons to make sure I'm doing the right thing beforehand. Because I can't say I've heard of a surgeon reattaching it. It's definitely in the literature, right? But none of the people I've ever worked with have considered repairing one.
Yeah, okay.
Yeah, that's good to hear.
Yeah.
Yeah, what's your kind of opinion and thoughts? I'm thinking of a patient I had a couple of weeks ago that lives a couple of hours away, had come down to see a surgeon, and she'd been said that she might need a pretty complex surgery. And then she'd seen the physio and then saw me. It was a roundabout way of coming to me, but she was just asking my opinion.
Surgery?
Pretty complex history of rheumatoid arthritis, lots of foot deformity, pretty debilitating pain, and it was going to be maybe an ankle fusion. I can't remember. It was a pretty complex surgery, and older, frail, and not much mobility anyway. But she was kind of asking my opinion actually about the surgeon. And I never ever comment on any other health professionals, and just say, it's always worth getting a second opinion. What would you say? Because especially in your field, I mean, in my field, I tell people if they feel like it, they can have a second opinion. Would you tell patients, because I think it's good to always have a second opinion, do you ever tell patients that, it's beneficial if they're concerned?
Oh, absolutely. Right. Yeah. Like the other thing as a surgeon, you'd much rather you initiate the referral than the patient does it themselves. Right. You're looking for backup, but I always say to patients, look, these things are complex. You might get a completely different opinion, right? So in which case, then you've got somebody to consider, or you might, fortunately for me, if I send it to someone else, they might say exactly the same thing. In which case, that gives patients much more confidence that they're going into this thing and it's the right decision, right? I think in the past, there's been a real reluctance to get a second opinion because it makes you look unsure. But as I said before, like these conditions that we're dealing with are incredibly complex. And the surgery is good, but not perfect. And so the more people that say that for the patient, the more they're likely to get the message, and the more likely they're going to have confidence that people are doing the right thing. I mean, when you get a question like that, Blake, that's a really hard position for you to put in, right? Because you either way, you can't really win, right? If you say, no, he's fine, and something goes bad, makes you look bad. If you say, no, I think you should get a second opinion, then you wonder whether that feeds back to the surgeon, right? And this has happened to me when I started, right? I had a patient see a podiatrist after I'd seen them. I booked them for surgery. All of a sudden, the case was cancelled. I was like, what's going on? She's like, I saw this podiatrist and they recommended someone else. They hadn't heard of you.
It wasn't me, was it?
Right. No, another podiatry place in town. So, but, and look, it's fine people have opinions, but you can't sort of throw the other health professional under the bus.
No,
right?
and you've got no understanding about that.
No, so, I mean, and look, this happens, right? I mean, you always try your best to have a good relationship with the patient, but sometimes the message doesn't get across or they don't feel comfortable with you. And it's actually better than the patient goes somewhere else, because a big part of the healing is actually trust, right, with the professional. And you're going to have, I mean, it does hurt as a clinician to see them go away and think that you haven't, like, that they're not confident in what you're doing, but you've got to put your ego to one side and say, well, look, it's probably better off for the patient and yourself that happened, right? My approach to that, if you're in that position, look, if you're not sure, go ask the surgeon again, have a list of questions, right? Just to make sure you're happy, and ask them, are they happy for a second opinion just because you're not sure, right? And a good surgeon will do that. They'll say, if I've got a patient that's hesitating in front of me, I say, look, this is not straightforward. Most of the time you go to a surgeon and we say, do this. I'm saying to you, these are the risks, these are the benefits, make your choice. But if you're not sure, let's get some more information. Why don't you see someone else and see what they think, right? And I think I reckon second opinions are very, very beneficial. I think as the clinician initiating it, you probably lose about 40 to 50% of the patients that you do that to, because you are putting yourself in a position where you don't look as confident, but you just got to accept that, because ultimately what you're in it for is for the good result for the patient, right? And you don't want to end up in a position where you've not got that. And surgery, there's risks with surgery, right? For an ankle surgery in particular, things can be imperfect. And so you're much better have got two opinions if you're not sure about something or the patient's unsure about something. And
like that's the truth as well. It's not like we're saying getting a second opinion because I've got no idea what we're talking about. I'm really unsure, and you're only advocating the truth to the patient. No, it's better than saying, yes, I know exactly what I'm doing. Don't listen to anyone else. Let's do this. Because there's nothing in, especially sports medicine, but anything in musculoskeletal rehab that's 100%. Like, even if you're the most confident, sometimes it just doesn't work.
No, I mean, if you look at that guy, the snowboarder, right? Like with the general vertical talents, like that's extremely risky for the surgeon, right? So as in for the outcome for the patient. So having 2 or 3 people say, hey, look, this might not work out how you like it. Excuse me. Is beneficial, right? It will at least make that patient know that, okay, I probably need to do this, but there's a real risk to it. In terms of what I want to do, in the future.
It's probably easier. I'm just thinking of patients that I've seen who have, like, say, come to me for a second opinion, and they come in and they're like, oh, well, this person told me this and I'm not too sure about these things that they said. So you kind of already have that win above that previous clinician.
Absolutely. It is so much easier to be the second.
Yeah.
Like it is so much easier to be confident, you're like, oh, well, I think this. So, I can understand why that person thought that thing, but I think this. But ultimately, it's your choice who you really want to go with, right? You say that to the patient, and I'll be honest, like when I'm a second opinion person, they often stick with me, and when I'm usually sending them to someone else, they usually stick with that person, right? But that's a perception thing, and that's okay, right?
And I think as you get older, especially, and I always say when I started off, like when I was younger, if someone would come to me, I'd be like, oh, as if you would do something like that. And then you realize that that's the complete wrong way to go about it. And now I just say, that's great. We've got the benefit of hindsight. We know what worked and what didn't. If anything, it's beneficial. Now we can do these things because we haven't tried that.
Yeah, absolutely.
Yeah, that's good. All right. Well, I did want to ask about, Which question, actually, do you want to ask? We'll finish with one more so people have got some time to listen to it.
Why don't we just ask them both?
Yeah,
we've got two more questions that we want to ask. And then we'll link them. This could be another 45 minutes.
Yeah, so you asked.
So we wanted to just quickly touch on a bit of chronic ankle instability, where we did touch on the deltoid ligaments stuff, which kind of plays into it a little bit. But I guess chronic ankle instability sort of, begins with an ankle sprain. How does it progress into chronic ankle instability? Is it, what we were talking about previously, where maybe the deltoid ligaments involved, or maybe there's a talar dome lesion that hasn't been picked up, or is it bad rehab, or what would you say?
Yeah, I know I'm answering a lot of these questions in the grey, right? But that's $1 million question, right? So if we could pick out the people that are going to go on to chronic ankle instability, I'd be operating on them straight away.
Yeah.
Right. The problem is it's hard to pick. And to be honest, you probably see this too, Blake. You have those patients that got really cavo varus foot, really high arch feet, hindfoot sits in varus. You think they're going to be the ones, right? And look, the percentage of them are, but they've had those feet for a long time, right?
Yeah.
So why now? And you do get those patients that are the chronic, and they're the ones probably I would watch more carefully. But they're not your typical chronic instability patients. Like, they've got another reason, right? Like, they're probably never going to get better unless you change. If they've then developed instability, even though they've had their cavo varus feet for like 20 years, and all of a sudden they're very unstable, just stabilizing the ligaments for those people is never going to work. I've actually got to change the shape of their foot, probably.
Yeah.
But for your average person who keeps spraining, they're hard. They are going to be, like, when you initially see them, they're very hard to pick, right? Because it's not based on the severity of the sprain. It's not based on the mechanism. It's not based on their BMI or their heights. Like, there's been a few studies looking for reasons, but they're not been that definitive in working out who are those people that are going to go on to develop chronic instability, right? And I sort of thought probably a year or two ago that that we could probably weed them out if we gave them more physiotherapy. Right? There's actually 1 or 2 studies out of Canada where they actually tried to give all of them physiotherapy versus just giving them a card to do some exercises, and they did much the same. Right?
Damn.
Right? Yeah, I know, right? Because I honestly thought physiotherapy. I do. Don't get me wrong. I send people with physiotherapy, right? Like, absolutely think it's worthwhile if they come to me with an ankle sprain and they get physiotherapy, right? But maybe it's not as valuable as I thought. Yes, right. I still don't want the message out of this podcast to be, got an ankle sprain, don't do any rehab, right? I definitely think if you
I can see the tears coming down Kelly's face.
No. Like, trust me, I probably just lost about 30 different referrers when I said that, right? But I do think it's useful, but it may not prevent those people who are going to be chronic sprainers, I guess, right? What I can say is that I do say to patients, look, you've got to give it. So for me as a surgeon, it's a tick box thing, right? So over time, I've sort of found locally who I trust to do good rehab, right? When you guys, you do podcasts and things like dry knee and that sort of stuff, right? Well, they're sort of red flags to surgeons and therapists too, right? So, right? Yeah. Okay. So
good to hear. Good to hear.
Right? Yeah. Look. I mean, there's going to but as a surgeon, if you're referring to physio, you're mostly referring for
rehab.
Range of motion, strength, proprioception, right? So anything outside of that is wasting the patient's time. If it's got a small effect, okay, yeah, great, but that's not really what I want them there for, right? So that does play, right? So that plays into the referral for the surgeon. Now, it's a bit tricky then if the patient's got a prior relationship with the physiotherapist. You don't really want to wrench them away with that because, like I said, the trust thing is important to me as well, right? But I think all patients that have a sprain should do some level of rehab. But same thing as the pain thing. If they're probably a bit longer with the instability, if they're getting out 2 or 3 months and they're still unstable, so they either have a sensation of unstable or they do keep spraining, then you've got to start to think, well, they're probably not going to get better, right? In saying that, the literature is a bit unclear on that. Some people would argue 2 to 3 months. Other people would argue 6 to 12, right? But I found most of my patients that come to see me they've usually had multiple sprains by the time they've come to see me. Some of them have done physio and got a little bit better for a while and then sprained again, right? So my usual thing is if they're not had any physio, I give them 2 or 3 months to see if the physio can regain the stability. And if that fails, then usually I'm looking at stabilizing, basically. That doesn't answer your question again, right? I've gone off on another tangent. But
that's okay.
We know it's like that. That's how it is.
Blake always asks me questions and I never answer them as well. So
it's never black and white.
But basically the answer is don't know, right? Which is really annoying. Like, because otherwise I would be fixing the ones I was really worried about, but you can't. All I can say is you've got to watch for it.
Yeah.
Right. And that's where your physiotherapists are important. That's where your GPs are important to say, okay, and even your podiatrists, right, are important. That if they're not getting better, they're still got instability symptoms that you can't just say it's going to get better now. If they've had good rehab, they've failed. Now it's something they've got to do something about it. And that operation, I can say, is pretty successful.
Yeah, that's good.
And that kind of leads into our next question about the development of ankle osteoarthritis. Is the reason that you're wanting to operate on those, if you knew that they were coming to prevent that condition, is that a big part of it?
Yeah, absolutely. So, but once again, we don't. So it's interesting. Like a lot of surgeons would argue, for instance, like ACLs, that an ACL that's left for a long time potentially causes knee arthritis. And you'll find some surgeons. What's that? Sorry,
I've heard that like commonly. Is that?
I don't think that's true though.
My understanding is it's still unclear, right? Yeah. Some surgeons vehemently argue for, and look, I'm not a knee surgeon, but there's arguments for and against, and there is a bit of literature that tries to argue yes, but you've probably got to have like a long-term follow-up to really work that out. The same's not being done for ankles, right? You probably could do it because there's a lot of ankle sprains out there, right? My theory on that is, yes, I think some of the chronic instability patients will develop arthritis. There's some biomechanical studies on ankle injuries that if you go through the CFL in particular with your injury and it remains a problem, that your axis of force that goes through the ankle actually shifts posteromedially. So it changes the axis where your force goes through the ankle.
Interesting.
So funnily enough, it moves towards the shoulder of the medial talus, which is where we see a lot of OCDs. Right, typically in a chronic instability patient, your ankle, you'll see it in the medial shoulder, right? Which the biomechanical stuff matches up in that regard, right? So if you do that, it's the same with syndesmosis. So if you do a syndesmosis injury and you go through all 3 ligaments of syndesmosis, your axis of force goes posterolaterally, right? So it goes sort of the opposite direction.
Yeah.
So you change the axis and mechanics of the ankle for a long time, and the general principle of orthopedics is if you do that to a joint for a long period of time, we think there's more likely to be arthritic because your cartilage is developed to be thicker in some places, thinner in others, depending on how it's supposed to move, right? So if you change that, you would think that ultimately that's going to cause more damage. But we don't have any proof. We can't link chronic ankle stability to arthritis based on the literature.
Correlation kind of thing, causation.
So yeah, because that's true. Yeah, correlation. Yeah. So, but I do think actually probably more sinister is syndesmosis, right? I think, so I certainly have in my practice seen, you guys will be familiar with a Weber C fracture to the fibula, right? Typically that's associated with a syndesmosis injury, right? I think, I might not have the timelines on this, but maybe 30 years ago, 25 years ago, people typically would just put a plate on the fibula bone, just fix the fibula, right? So the syndesmosis wasn't always addressed. And I've definitely seen patients come through my practice that are 20 years down the track from that, where I say, it was never quite right. And they've got this horrible arthritis to their ankle, right? And then we see these, and ankle arthritis is very different from hip and knee, and that it's supposed to be, from the literature says, mostly post-traumatic, whereas hip and knee is far more genetic.
Yeah.
Right?
Yeah.
So, and I do think there's probably a group of people that have had a syndesmosis injury or even a soft tissue syndesmosis injury maybe 15, 20 years ago, right? And their only symptom might be, hey, when I go to pivot, it just doesn't feel right. I get a bit of pain when I pivot, right? But walking day to day is fine, running straight lines fine. I'm okay. But all that time, the ankle's just been subtly not right. And over time, that causes, that potentially causes a degenerative change. But they're all theories, right? Like no one's done a longitudinal study that says, okay, we followed all these ankle sprains for like 25 years and this many people got chronic instability. And then of those chronic instability people, this many people got arthritis. I'm not aware of. Once again, I'm not aware of that of a type of study that shows that. Certainly, if someone's got one, let me know. But so and you got to look at the knees, right? Knees are much more heavily studied area, and I think the jury's still out on that. And so, because what you're looking for as a surgeon is a reason. You're looking for a reason to justify surgery, right? And so, the knee guys that want to use an ACL reconstruction as a reason to justify reducing your risk of arthritis, not just stabilizing the knee, but reducing your risk of arthritis in the future, right? Same as ankle surgeons. If we thought they definitely cause arthritis, then we should be stabilizing a lot more, right? But I guess we can't talk about that from an evidence-based standpoint, right? Or we can say the mechanics might say that that's what happens or is likely to happen, but we can't say for sure.
A bit like, I hope it's similar, a bit like saying, cavers feet are always going to develop lateral forefoot or lateral perineal pathology, and you see plenty of cavers feet, no issues, no problems at all, or no ankle issues. Yeah,
exactly, right? So, I mean, that's the problem, right? Is that there's a lot of these injuries we have an understanding of, but we don't have a complete understanding. The body's more complex than we give it credit for, right? So we think we know these things, but we probably don't.
And like for people listening to this, I mean, it's great to be confident and have an understanding, but you've got to be transparent with your patients. Like, you can't say this is going to happen when I do this. Like, someone like yourself, if you're not 100% confident with your background, I don't understand how some clinicians can be so confident with what they're doing. Don't get me wrong. It's good to have confidence, but you've got to understand that it doesn't work all the time. And I guess explaining that with your patients as well.
Yeah, and the temptation is you just want to look confident, just say, this is fine, right? And the patient looks at you like, I trust you, great, fantastic. Because trust and confidence probably actually contributes a fair bit to the outcome. But I honestly can't sit there and lie to the patient and say with half these things that it's 100% going to be right. Like, patients often look at you with two heads when you say, like, so my thing with forefoot surgery, right, is that a common saying for ankle surgery is that you can do the same operation on two toes. You're talking about the lesser toes. Same operation, be just as confident with both of it. Two toes at the end of the case, like 3 weeks later, will look completely different, right? And I'll say that to patients. They look at me like, "What? What do you mean?" And I was like, "Well, literature says there's a deformity rate of this. I can say from experience and I can say from looking at other people's work that this happens, right? I just need you to be aware of that." Right? If that changes your decision, fine, but you need to be aware of it beforehand. And I hate talking about it because you look like a mug. You honestly look like you're not confident in what you're doing. But you gotta tell people these things. They're putting their trust in you, right?
Yeah, and hard for patients to get that as well, because they definitely think that in the kind of sports medicine musculoskeletal world, we've got everything worked out. Like, great, you've got this condition, awesome. We just do this and you get better. The body's not variable or complex. We just treat you like a car and you get better. It's just not like that.
Just not. No, definitely not. Definitely not feet. Well, definitely no. I'd say probably knees either, right? But you're right. So musculoskeletal is complex and challenging, right? The good news for you, Blake or Kelly, is that most of your stuff is reversible, right? So it doesn't like your orthotic, take it out, you change it.
Yeah, which has never happened, by the way. No.
But same with physiotherapy, right? You do your exercise, your rehab, doesn't work out, or if it's causing a lot of pain, you can change it up. I do something, I can't change it, right? I can make them worse, right? And I can't reverse it half the time. So that's why I gotta be super honest with my patients. Like, if there's, they got to know what the risks are and the potential complications or potential unhappiness.
Yeah,
right?
Yeah, that's true. And like we talk about, and I always say, when we're referring to orthopedic surgeons or the sports doctors or back to anyone, we're not in a place as allied health, I don't think, to comment on what should be done or what might be done or what might be the complications. Generally, it should be just suggesting, I think it's beneficial that you get a review with this person for these reasons, because we've done everything that I can do without great improvement. You definitely shouldn't be saying, and I always use like a bunion example, or even like the ankle OA. Yep, just go and see the surgeon. You'll probably have this surgery. These are the complications. It's a pretty good surgery. You're just not in a place to comment on that. It's just, you should be just sending there for a review and explaining that to your patients.
Yep. And I think the same goes with surgeons and rehab and orthotics and things, right? Like, if I'm being absolutely honest with you, I don't know how you make an orthotic, right? I have a vague idea, right? Actually, I found your podcast quite useful, right? So I know what I want. Well, I know what I'd like, but I do, like, obviously you guys have a bit of play with that. I might put something on a referral, but more often than not, I find you guys have modified it, which is absolutely fine. Right? And same with physiotherapy, right? So I know GPs, they'll write physio. Please do physio, right? I wouldn't say, as a surgeon, hopefully we're writing better stuff than that, Kelly. But usually I'm looking for, movement, proprioception, strength, but I don't really ever specify the exercises, right? That's an individual area of expertise that I don't have. And I actually tell patients, I'm a really poor judge of strength and mobility, right? Like we're bad doctors, we're bad judges of safety and mobility, right? And we're not great judges of strength either, right? So there's all health aspects, professionals all have their strengths and weaknesses, and you're right, you shouldn't comment too much on someone else's area, right?
Because you might get there and it'd be completely different.
Well, that's the thing, you really are boxing the other person in, right? Or you're potentially creating distrust. If you say, well, I'm going to send you this and they're definitely going to give you this thing, and then that person turns around and says, no, that's garbage, or no, I'm not going to do that, I'm going to do something else. The patient's sort of like, oh, who's right here? Like, who do I choose, right? And that leaves them a really tough. They just lose faith in the whole process. Right?
What would your advice be for something like an Achilles rupture? So I'm actually thinking of a patient that we both share who recently ruptured her Achilles, and they're asking you, what's better, operative or non-operative management? How do you advise us to give them advice on a question like that, where it kind of is a bit 50-50-ish?
Oh, absolutely.
What would you suggest?
Well, I actually have a video on it, right? So I've got a video that basically goes through what the sort of pros and cons from my perspective, right? So that will vary from surgeon to surgeon a little bit too, right? Basically, what I say to them is most things they come to me for, I say, you need this for this particular problem. It's your choice, right? And here are the pros and cons. So what I found with Achilles is that what we know is that probably the results are pretty similar at 12 months in terms of function and re-rupture rate, right? We used to operate on Achilles because we thought the re-rupture rate was much greater without an operation, right? That used to be our excuse. But as we've gotten better at non-operative management, there's been more studies done. The re-rupture rate is pretty negligible compared to operative and non-operative, right? So I usually say to them, look, re-rupture rate, there's no difference. Function, there's probably no difference. Strength, there's some studies that show there's about a 15% difference at 1 and 2 years if you have an operation. But given the functional results are pretty similar, I think that 15% strength probably only matters to people that are competing at a high level.
Is that 15% higher with operative?
Yeah, higher. Higher. Yeah, but that's in a lab, right? So who knows how that correlates clinically, right? Like, what do you need that 15% for? Do you need that 15% to go up a step? Or do you need it to, beat the Queensland winger that's trying to tackle you in the state of origin, right? Like, how do you work out who that matters to? So the problem we got is that all athletes get operations, right? People turn on the news, they all get them. And to be honest, I do the same. Like, I offer the athletes, like if I've got a Newcastle Knights first grader, they're getting an operation, right? Because that 15% to me, even though I don't know what the clinical correlation is, that might be the difference between them, making the origin team, or if they're a reserve grader, making the starting team, right? Or if they're a track and field person, that might be the difference between a couple of seconds, right? Potentially. So those people get it, but for the average person, I say, well, it's probably 15% probably doesn't matter that much to you, because we know the functional results are much the same at 12 months. So that's the spiel I start with, and then they sort of go, well, okay, what's the rehab, right? Like, is there a difference? There's some studies that show you get back to work about a month earlier if you have an operation, but there's others that say the opposite of that. My protocol at least actually has a difference in it, where they actually come out of a boot about a month earlier and they're walking about a month earlier compared to if they don't have an operation, right? And that, funnily enough, I found, so most of the time when I have these chats to people, I think they're going to go for non-operative management, and they more often than not will go with a surgery, funnily enough, right? That 4 weeks often means a fair bit to people, right? They hate the idea of being in a boot for ages. or off the foot for a long time. And they also can't get their head around how the Achilles heals if I'm not putting anything in it, right? And I also lay it down. I was like, you have to be really strict. You dorsiflex that ankle at all in this rehab process, we're starting back at square, right? And so they think, oh, geez, I'm going to be stuck in this one position for a long time. What if I make a mistake? What if I have a fall, right? So I give them these sort of things, and then I say to them what the risks are with surgery. And so the risk of surgery is around about a 5 to 7% issue with the wounds, right? And then I say to them, well, look, the skin, there's no matter how fat someone is, there's not much skin, there's not much between the skin and the Achilles. Everyone can feel their Achilles tendon, right? That wound gets infected, high chance of the Achilles getting infected.
Oh, wow.
If you get a bad enough infection of the Achilles, you could end up with the Achilles actually taken out, or you could end up with an amputation. The worst case scenario, that's really low risk, but it's still a possibility, right? And that's devastating. Yeah. And that's sort of how I put it. And then I wait for him to make a decision. And often they're still unsure, right? So the patient we had, Kelly, I think it's the same thing. And I get the impression she's still unsure, right? And so the other thing is that in one consultation, when I say all this stuff, they're going to forget about 75% of it when they walk out the door, right? So that's where, like, I've got a video on my website or the YouTube channel, and I say, look, you're going to forget all this. Go watch this thing again. That goes through it again, so you've got it clear in your head. Ultimately, the decision is yours. Whatever decision you make is not wrong, right? Whatever decision you make, it's got to be worth it for you. That process changes a little bit if I get someone like 1 week down the track. Then my talk to them changes, because I'm usually more in favour of an operative approach in that regard.
If they haven't been in plantar flexion.
If they've been in nothing, if they've been either not picked up or not. So usually I want them in plantar flexion as quickly as possible. The reason is that brings the 2 tendon ends back into a position, right? Because it's not going to heal properly if it doesn't. The biggest, I've forgotten your presenter's name from London, but I agree with him. He was talking about the tension of the Achilles. Yeah. That is the single most important thing about the Achilles in terms of treatment. So if your Achilles heals long, you are never, ever going to have power in that Achilles.
Which is so important to
have. Yeah. So
you
need the Achilles to be, 2 ends of the Achilles to be touching one another, essentially, right? If it's been a week before you've had any treatment, the body forms a hematoma, so a collection of blood between the 2 ends, right? And the worry is that you may not be able to get those two. Like, if you then go put them into plantar flexion, you would be concerned that the 2 ends aren't touching one another, right? And that the Achilles will heal. The body will lay down scar between the 2 ends, but you'll end up with a tendon that's like 1 or 2 centimeters longer, right, than what it's supposed to be. And the way I put it to patients is I say, look, if I'm in the corner of one room and someone puts a boulder in the other corner of the room, if I was pretty good with a rope and I could lasso the boulder, right, but my feet were in concrete so I couldn't move, if someone gives me a rope that's the right length, as soon as I lasso the boulder, I'll have tension on the rope and I can pull it towards me provided I'm strong enough, right? But if somebody gives me a rope that's too long, then I'll have slack in the rope. And if I can't move and I can only pull it once, like I can't just keep pulling it towards me, then I won't get any tension on the boulder and I won't be able to move it. And in that scenario, the boulder is your heel, the rope's the Achilles, and the person, me, is the muscle. Yeah. Right. So, if that patient's not got into plantar flexion early, then very much I will talk them into an operation. Right. But otherwise, if they've had good early treatment and they're in plantar flexion, then it's their choice. Right. And that's where things like sometimes a second opinion, trying to reinforce it with the things like videos or a sheet for information, that sort of thing. Patients will often have talked to other people they know have got an Achilles, had an Achilles, right? They're often still very unsure, but I can confidently say that I've got patients that have done very well with an operation and patients that have done very well without one. Right? So I know they both work. And funnily enough, depending where you are in the world, your treatment will change. If you're in Canada or the UK, almost universally, you get treated without an operation, right?
Yeah, okay, interesting.
If you're in the States, you'll get an operation because of birth money, right? If you're in Australia, you get a bit of each.
Yeah.
Right. So,
so
they both work. The harder question is when people say, "What would you do?"
See, that's the question that we often get asked.
We got that yesterday.
It's like, so what would you, what would you do? What do you think I should do? Should I operate or not? I know that there's 50-50, but what should I do? Like that's where I struggle, because I'm like, oh, well, it's kind of just your choice,
Yeah. And you can't give them what you would do either. Yeah.
No, and the other thing is, like as a surgeon, right, we only think of the bad stuff. We only remember the stuff usually goes wrong, right? So like, as a surgeon, I'd very much not want a knee replacement, even though it's a very successful operation. I can only think of the bad stuff that happens, even though 95 times out of 100, only good stuff happens, right?
Yeah,
so we've got a very biased view, like you guys do. So it's actually not actually that useful to know what we would do, because we've got a very different opinion to what the average person would do.
Probably just to my Achilles, a bit of dry needling, foam rolling, and stretching would probably get me there.
Yeah.
All right, that was great. So I did want to mention, and I'm actually going to put a little bit at the start of this, your YouTube channel. Yes. How the best way to find people, just to type in foot and ankle? What's the best way?
No, I don't think it's popular enough. If you type in
you've got over 700 subscribers. You're a bit of an influencer.
I remember like 860 now, right? So so probably the easiest way to find it. So actually, that's a tricky one, actually, because you even search it on YouTube, because it's called the Foot and Ankle Orthopedic Surgeon. But if you type that in, you go through about 50 things before you actually find the channel.
Yeah.
If you go to my website, it's probably the easiest way to find it, which is www.hunterfootandankle.com.au. So and is spelled A&D.
Yeah.
And then there's a little YouTube logo on as soon as the website comes up, and you just click on that, and that should take you to the YouTube site.
People listening, it's great, and like good to send patients to as well. And it's not you just sitting in front of the camera saying, this is what we do, this is what the evidence says. It's like interactive, there's pictures, it's just a lot easier to take in, and it's good.
Look,
it's really good.
I don't really want it to be about me. It's more, I mean, the other thing is there's plenty of ethical restrictions in terms of what sort of information we should be providing. So I very much try and go middle of the line when I can. So I can't really commit too much one way or the other at most things, but it's more just to give people an idea of what's involved in certain injuries, and for clinicians also to have something to go back over. So because, like I said, the biggest thing within a consult is that most patients will forget what you said when you walk out. So it's realistically, it's more for patients. So clinicians obviously find it useful, but it's aimed at patients themselves. Things like ankle fusions, people don't know much about it. People think a subtalar fusion is the same as an ankle fusion and those sorts of things. So it's just trying to make it as simple as possible. I've got to be honest, it helps me explain things as well. Trying to put them in the video, you've got to try and be as simple as possible. That people understand it. So it's great for me then to then extrapolate that when I'm actually seeing patients in real life.
Yeah, and you can really hash out the way that you would explain it to your patients. I think it just makes you better at it when it's like real life.
Oh, absolutely. I imagine you guys find that with the podcasts, right? Like and it makes you look things up as well. I can't say that everything in those videos I knew straight away before I put in the video. Like particularly some of the return to play stuff. I've got to admit, like that's stuff that I've found that's useful, but it's not widely known. And you get that heaps, Kelly. People will say, well, when am I going to get back to playing with ankle sprains, syndesmosis injury, all that sort of stuff? There's actually some data out there now that says when people will be getting back, and you say, well, look, this is what happens in an athlete. You're not playing for you're not playing for Barcelona, and they're getting physio around the clock. So you might be a bit later than that kind of thing, right? And
so most of our listeners, I think it's maybe 78% are in Sydney, Newcastle, or I guess East Coast, I guess. Maybe that's just on Spotify, but if someone wanted to consult or have, I guess, get an opinion from you, it's best to go through the GP and then just as usual GP.
I think so. I mean, I tend to recommend, I get plenty of referrals from allied health, so physios and podiatrists, which is fantastic. Like I do say to the physios in particular, I say, look, they're the people going to pick up things like syndesmosis injuries. So I got to say, like 90% of the syndesmosis injury referrals I get from physios. It's always good to have the GP. The GP always in the loop, because the GP has a good understanding of the background history of the patient. So I tend to recommend that. Certainly I can give an opinion without that, but it's beneficial to have the GP involved.
Great. Yeah, awesome. Yeah, so don't just message you on Instagram and say, "Hey, can you fix this?"
Yeah, I try not to do that. I just,
I can imagine you would get it.
There's a whole that's going to get a whole world of pain for everybody if I start.
Yeah, and like I can see the YouTube comments and like, "Hey, I've got this, the tiniest little sentence. What do I do?"
Yeah, I've got those. I've got to say, I'm not like, this is where I can't be an influencer, right? Like I can't answer comments on medical stuff online. Like I just can't be that guy. Like I didn't start it to do that. I literally put those videos on YouTube so I could store them somewhere so I could have them on my website, right?
Yeah.
And then I noticed there's a subscribe option, and all of a sudden we've got all these subscribers, which is great. Don't get me wrong. But it's more an explanation thing for patients. But the good thing is it's motivating, like you guys have found the podcast. Is
it's great.
You get a good response from people, you then want to do more, right? So you see it helps. So.
No, it's good. Yeah. All right. Yeah. Mate, thank you so much for coming on. Enjoy.
Thanks, guys. Thanks so much for having me.
Yeah, Sunday afternoon. And I'm sure we'll see you very soon.
Excellent. Thanks heaps. See ya.